Hello, everybody. Welcome to Tough to Treat podcast. This is Susan Clinton, the co-host with Erica Mello. And I'm just here to say we're ready to do part 2 of the podcast that we started 2 weeks ago. And this part is going to be about where's the driver. So I hope you enjoy it. Before we launch into the podcast, I want to remind everybody that our subscription to the Tough to Treat podcast club is going to be coming up in November. Erica and I are gathering together to do the final touches and get it going early this month. So we're very excited about it. And Erica, you want to talk a little bit about the website that's up now?
Yes, so we've recently redesigned our website and we migrated it over to a different platform that's just much more user-friendly for us. And it's toughtotreat.com, pretty easy, toughtotreat.com. And that's where you'll get all the information on the membership as well as the podcast. But you need, well, you don't need to, but to get we have some great PDFs that we send you when you opt into the site. So if you just give us your name and your email, pretty straightforward, you'll get a Clinical Pearls PDF that I wrote, as well as some sleep tips and chronic pain, the relationship that Susan wrote. And so there are 3 PDFs. They're fantastic resources. And that's where you're going to get the most information. You'll be like the first to know about the membership, et cetera, et cetera. So that's where you will hear from us outside of like social media. Okay, so www.toughtotreat.com. We would love to see you.
Thank you. Enjoy the podcast, everyone. Hi, everybody. Welcome to podcast number 108. I'm Susan Clinton, co-host with Erica Mello. Hi, Erica.
Hi, Susan. How are you?
I'm doing well. Looking forward to getting together with you this month. So this is part 2. So if you haven't listened to part 1, go back and listen to podcast number 107, where I introduced the client. And I'll do a little short recap, but we're going to kind of launch into what happened as I started kind of like playing around with some of the potential drivers that we kind of uncovered last time. So to recap, this is a client with chronic lateral pelvic pain and right hip pain, lateral hip pain, urgency, frequency with urine stuff, worse with stress, nervousness made her worse. And then also we revealed chronic back of the neck and fullness of the head and neck, pain and secondary dizziness. But it was more like an imbalance than a dizziness, kind of like, kind of not like true dizziness, like the world spinning, but kind of just feeling off. Relies on vision for her strategy quite a bit. And we talked a little bit about the fact, her history with 2 motor vehicle accidents 1 year apart, and also 2 falls with ankle sprains after the MVAs, and those were on the right side as well. So we kind of took us through, and one of the other issue that she had is that after she exercises, because she likes to do really intense exercise, she has bloating, GI system kind of bloating. She also feels increased pain and symptoms 4 to 6 hours after she exercised. We talked about the neuroimmune effect of chronic pain and pushing, and then what happens later, in the day, and not really thinking that it was the exercise that was causing it, but more other things on her end. And that if she sits and looks at the computer for longer than 2 hours, she really has an escalation of her symptoms. So one thing that was really of note is that sleeping really helps. So when she's able to get to sleep, she feels much better. So quieting that system down, getting kind of cocooned, just that whole safety aspect probably as well for her neurosystem really kind of helps her settle down.
Yeah, so refresh my memory. When she's sitting for a long period of time, you said all her symptoms ramp up, everything, like the urgency, frequency, and
all of her stuff. So everything kind of comes together. She was complaining mostly of the pelvic pain, and the urgency frequency bit, but when we talked, when we kind of pulled it all together, there was this whole cervical stuff. And as I was watching her original movement things, always off to the left, and kind of thinking about the right foot and what was happening there, because she didn't have great control in her right foot. But when we started doing things like partial squats, bend overs, stuff like that, her feet were staying on the ground they looked pretty good, so kind of started thinking, that's where we kind of left it, like we're going to travel up now and see what else we could find out with her. Okay, are you ready?
Perfect. All right, I'm ready.
All right, I know you have your thoughts about what her driver is.
I do.
Yeah, so I'm just going to fill this in a little bit for you, because that first day I just did some autonomic quieting with her, and we discussed, as I talked about at the end of the podcast, that if 2 hours makes your symptoms worse, can you, how long can you work and feel good and take breaks? So, and how long of a break do you need before you come back, to it? Yeah. Can she, change her activities and not sit for 2 hours and like start to really feel bad? So that's what she went home with, was to kind of do some discovery that way. And I gave her some autonomic quieting, to do, to kind of settle her system, start to put the brakes on that system throughout the day. So then she came back, and one of the things that she talked about was that it was interesting if she, when she was sitting and kind of paying attention to it, that she noticed things, she did okay for a while, but it was when she would kind of like, I guess, peer into the computer, she would start, so it's kind of like eye fatigue she was complaining of. It was hard to she was having trouble pinpointing it. And she'd say when she did that, she would feel off again. And, so she was wondering if it maybe was that rather than just sitting, and staring at the screen. So we kind of discussed that it's probably both. So I asked her to show me what that meant. And what she did was she sat in the chair and she leaned forward, and, and her head, she had some cervical hyperextension at that moment. And, and she would kind of like she would show me like how she would be like leaning in to really look at, small numbers and things like that. And that after she did that for a bit, so I had her just kind of sit there like that for a little bit. I just wanted to see what would happen. And she says, well, I don't have the computer in front of me. I said, I know, let's just see what happens though. And sure enough, after about 10 minutes, she said, I can start to feel that fullness in my head. I'm feeling off. I feel like I need to go to the bathroom.
Just 10 minutes of quiet sitting in the office.
Well, sitting in that position with her head forward and a cervical hyperextension, leaning forward. Extension. Yeah, so not just sitting quietly, but sitting that way. Actively, so that kind of tipped me off a little bit. It was like, okay, so there's definitely some positional stuff here that's going to be an issue for her. And it really kind of comes on rather quickly. So we did a little problem solving right there. I said, what would happen if you increase the font size on your computer? So you wouldn't have to lean in and stare so much. Or do you have glasses? Can you get glasses, that will allow, that you can wear just at your computer, that will, make everything bigger? It's, there's a couple of ways you could go about it. She said, yeah, I definitely can. She never even thought about it. Like, and I said, there's something about this position with your neck that tends to kind of, be part of this whole system kind of upset that's going on. And remember, you've had a whole lot happening, like I said, there was a, change of, a not so nice home environment, during all that time with the car wrecks and all the different things that happened. So she's still kind of like, in many ways, just kind of living in survival mode still, even though things are better, she's very nice, happy person, there's her system is still, kind of staying in flight or fight survival mode all the time. And she does feel better when she sleeps. So I took that opportunity to say, let's go lay down on the bed and get things to calm down. So she did. She immediately grabbed 2 pillows because I have pillows over on the side, and put them down and laid her head on the pillows so that she was in
on 2 pillows.
So she was in some cervical flexion.
And
I said, that's
interesting.
Right. So I just went with it. I just said, just tell me when things calm down. We chatted a little bit more about some different things, and, kind of, and did the urgency kind of slow down a little bit. And it did when everything kind of settled down. So she thought that was interesting because she never had kind of put those together in that way. So
were her knees flexed or straight when she was lying down?
She had her knees bent.
Were her knees?
Yeah, she was kind of had her knees bent. She was just kind of laying there quieting, you know.
Yeah.
So anyway, so after things calmed down, I said, what if we move one of these pillows? So she was like, she pulled it out and laid on it. And she said, not, you know, and she goes, it would be okay. I really would rather have the two. And I said, all right, what happens if you don't have any? And she goes, oh, I can't lay without a pillow. I get dizzy. Immediately I get my, you know, that it's not good. I have to have my head up. So there we go. So now what I'm thinking is I'm kind of going in between, all right, is this a vestibular kind of, you know, driver, you know, a bit, or is it some sort of dural thing? You know, so it was time to do some testing, because last time I did, you know, she would only squat halfway, you know, she would only do certain things, you know, but her, you know, her feet looked fine. They, you know, so it was, you know, so I just kind of like, okay, there is that little ankle sprain thing, but, you know, that may be like tertiary, you know, driver or something over there that may straighten up with this other stuff. You know, but so, and I did send her home doing the doorknob squat, you know, where she would have the hands on the doorknob because she liked having her hit something, and she liked the visual, you know, because she uses visuals to stabilize, you know, visual strategy quite a bit. So this time what I did, and these are over kind of a couple of, you know, this is not all in one time, but, you know, over some, you know, periods of visits here, basically went to hands and knees to see what she looked like on her hands and knees. And, you know, her head was up, you know, in cervical extension. And, you know, I just said, can you put your head, you know, I just put my hand on her ears and said, can we just, I got her into a neutral position for her head. How does that feel? That's fine, you know. And I just said, so I took my hands off and I said, just go ahead and rock back onto your heels, you know, hand heel rock. And as soon as she started to rock back, that head popped right up.
It went pop. I had the visual in my mind before you.
Exactly. And I said, can you bring your head? So I put my hand on her head again, and I said, let's go back down with your head. And as soon as I did, she started coming forward out of that, you know, heel position. So it kind of made me think, okay, she would only squat halfway. And, you know, is part of that because, you know, if her head isn't in you know, if her, because she couldn't put her head in hyperextension going down into a lower squat.
No, for sure.
Fall backwards, right?
Right.
So
that's right.
Yeah.
That's right.
So was it a vestibular problem, or is this a positional problem, or is something not moving where it needs to move? So, and with that in mind, we stood up and did a bend over, forward flexion. And again, cervical hyperextension. I just asked her to do it. I didn't tell her anything. When she was bent over, I said, can you stay there? You know, and she said, yeah, it bothers my hip a little bit. And I said, okay, well, what happens if you drop your head? And as soon as she dropped her head, she started to raise up. And I said, you know,
something doesn't like,
doesn't
like, say something doesn't like to be lengthened.
Yeah. So, and I said, you know, can you go further? And as she did, her head had to start coming up. It just like, she couldn't, you know, she couldn't maintain the range of motion of forward flexion with her head inflection, with her neck inflection.
Yeah.
You know, she had to come out of it. Yes.
When she was on, when she was, you may have said this, but I mean, when she was on her hands and knees, and did you like put her head like in a neutral position or flexion? And when she went back, what happened? She couldn't go back, right? You said?
Right. So what I did the first time is she got on hands and knees, and she was standing there with her head up. And I just helped her get into neutral, so her eyes were down looking at the bed. And then I took my hands off and asked her to go backwards, and her head popped up again. So when she was back on her heels, I got on her head, and I actually wanted her to come into neutral, and she couldn't do it without coming off of her heels. Her hips had to come up.
Got it.
Yeah. So same thing as like what you said. And so I didn't even bother to try to hold her there to go back, because this wasn't, you know, we were going to be fighting each other, and I didn't want to do that. Yeah. Right. Yeah. So
at both ends.
So I took her over to the wall because I wanted to see, she likes the strategy with her hands on the wall, hands on things, hands on the rower, the boxing kind of visual, straight ahead kind of, things that she was doing. I thought, let's get the wall involved here. And, and see what happens with her legs extended, her knees extended rather than flexed, like she was hands and knees on the bed. And, kind of just like that, like what you call like a wall dog, basically I had her start with probably about 125 degrees of shoulder flexion, hands on the wall. And I just had her kind of walk backwards so we could get a little hip flexion, keep her knees straight, and see if she could lower her trunk down into a little bit more shoulder hyperextension, which she could cope with pretty well. And I could coach her into a neutral head position. But when I brought her, so I said, let's slide your arms down on the wall. So now she was about 90 degrees of shoulder flexion. And I had her go, walk backwards a little bit so that we're getting into 90 degrees of hip flexion, but shoulder extension. And she could not do it if she dropped her head. She could not bring her head down. It bothered everything for her to bring her head down into that position. So now we've got a little neural tension stuff going on too. But I still don't think I think neural tension is secondary to what's happening. So I thought, you know what, I'm just going to go back and we're going to do an old-fashioned slump test. I just want to see what this looks like because I have to figure out how to play with this a little bit more. So I had her sit on the bed and, I had her, I said, let's take your non-symptomatic side, which was her left side. And I said, just straighten your leg, pull your toes back. Everything's fine. I said, slump down. And she did. And I said, can you drop your head? And as soon as she dropped her head, she said, it brings on all my symptoms. And this is the non-painful side. So I said, so you can imagine what happened with the painful side. She was able to not, she could get the leg up, she could get the foot up. And as soon as she started to slump, if she dropped her head even slightly, it brought on her symptoms. So I said, raise your head up, symptoms go away, drop your head down, there they are again. So I thought, okay, so let's take a real good look at what's happening at the, the cervical, spine and the cervicothoracic region. And, she had really tight suboccipital muscles, of course, right? Everything. So it just didn't feel like it was the upper cervical was the biggest issue. It felt like it was coming, especially because of the head moving on the neck. It wasn't the head moving on the neck. It was the neck moving on the torso. It seemed to me more. So
yes.
I just did a real quick assessment, tight as, just really hypomobile through, T1, T2, T3, T4, just, really, just being held pretty rigid. So we went back and did, I got her to lay down on a pillow. I bent her knees up, and we did a little bit of a breathing assessment just to kind of see what was going on. And, as soon as I took the pillow away, so she could breathe nicely, nice, thorax is expanding, little belly expand, it's just all moving very nice. And then I took the pillow away and immediately she went into that axillary, breathing where that, where everything's kind of just like the ribs are being pulled up, towards her head. And she started having symptoms. So it became very interesting to me. So she sat up and we started talking again. And I said, tell me about exercise again. And she's, she says she really likes it really high and fast because it makes her feel better, and I'm just like, what can you describe that for me? And she said, well, when I first start, I feel like I can't breathe and I have a lot of trouble, kind of like I almost feel anxious. And then as I get going with it, I settle in. So if she's on the rower, she starts and it feels like she can't, that she's having problems breathing or she just feels like she's just anxious. And I said, is that the same feeling you get when you were sitting in the chair with your head forward or when you're peering into your computer? And, she thought about it for a minute. She said, yes, that's it. So it seemed to me that what happens when she gets into certain positions, it really begins to affect her ability to breathe the way that her body wants to breathe. And she starts into this kind of like, we associate with like pain or panic, or, you know, that's that kind of all like, you know, hyper respiration.
Hyper vigilant. Yeah. Hyper.
And
Yeah.
so kind of like, is that running her into acidosis? You know, when she does that, and then it takes, so she
Yeah.
burns off, right? So you get you can start blowing off you know, the carbon dioxide, and you get, you know,
Yeah.
things start burning off, and then, you know, she can get into a zone for exercising, and which is why she's kind of attracted to it, you know, that faster
Yeah.
thing, even though it makes her feel bad in the beginning. When she can burn it off, she feels a little bit better. And, you know, so that's why exercise, you know, she likes it, but when she sits, she doesn't have any way to burn that off when it happens. You know, it just like
No.
starts going, and she feels really bad, and, you know, it has to go to the bathroom. And so that kind of like associates with that urgency frequency quite a bit. So yeah, you know, I know people are out there thinking, well, you know, her pelvic floor is probably over recruiting. And it's like, sure it is. You know, she's in survival mode. I don't, you know, like, I agree 100%.
Yeah, of course.
But it's
Yeah.
not the driver. It's not the
Right.
driver.
That's a
It's
strategy.
being
Right.
driven. Yeah, it's like part of the circuitry that she's in. So I decided that, you know, I think that there's, you know, it just kind of just stuck with me that something's being super protected around that area, that upper thoracic part. And I just thought, you know, I'm just wondering if this is a bit of a dural, you know, restriction here, if that's the driver here. You know, she's been in 2 car accidents, and there was other things that happened in her life. And, you know, and I thought, wonder what, you know, so, you know, here's the thing is like, okay, yeah, there's neural tension. Yeah, there's over recruitment. Yeah, there's all this dizziness and imbalance stuff and this eye strategy. But if we don't get this other piece going, I don't think any of this is going to settle down. And the reason that I thought that is that I immediately started doing some eye exercises with her to see if it would help settle her symptoms down. And it did, but none of it was lasting. So she went home with them between one visit and another, and she loved them and they helped, but they didn't, you know, as soon as she would do stuff again, it would start all over again. So it's like, okay, that's a good thing, because those are going to be a strategy to keep help, you know, it could be a nice reset.
Yes,
you know, exercise for her. But we got to get at, it's still not, you know, and it wasn't lower in the thorax, but that's, I'm wondering why that feels so good when she has her arms on something or her hands on something, because it helps her kind of protect the area somewhat, or keep it from moving, or what, lower the involvement of that upper thoracic area so that the rest of her can like do things. Your thoughts?
Yes, I have a few, but I'm getting, well, I want to go back to the wall, but I'm getting this image of when you have a turtle, and when the turtle's head goes back into the shell, it's almost like her head goes back into the shell, right? Because her doesn't like to be lengthened, right? Like, I just don't want to be out, right? Now, question on the wall. When she was at like 125 degrees of shoulder flexion, she went into a squat, versus when she went down to 90. You said when she went down to 90 degrees, her symptoms came on. Explain that to me again.
Okay,
I'm trying to get that wrapped in my head.
We didn't squat. We did like a downward dog on the wall.
Oh, down dog. I'm sorry, a down dog. Correct.
Yeah. So when she was up with her arms up higher, she did a little bit better. And I think it's that turtle thing you were talking about, because she didn't have to lengthen. And her trunk didn't, you know, she could only go back so far, and you can't get into 90 degrees of flexion at the hips. So in that in that range of motion, she could cope. But when we got her into a lower, you know, a deeper range of motion at the hips and at the shoulders for, you know, and the head had to lengthen, you know, if she could still do her little thing, but it brought all of her symptoms on.
Got that. Yes. Yeah. For some reason, I thought squat. I'm like down dog, of course. I also think that, you know, you think about with like the listeners, like she had 2 motor vehicle accidents, right? You know, the dural, like the cranial dura, right? There's so much, it's got to be in some way, you know, affected, whether it's a restriction up in the cranium, like at the tentorium cerebelli or something like that, or lower down at the cervical thoracic junction. Every single movement that you put her in, when the system's has wanted to be lengthened, whether it's from distal or proximal, her path of least resistance is just to shrink her head to go back into her shell. Right. And she's consistent with all you've done it sitting on all fours, squatting, standing, forward bend.
Absolutely.
You know. You know.
And so
she's pretty consistent.
Yeah, really consistent with that. So, and again, you know, the eye exercises would settle things down. You can go back and listen to some of our other podcasts, but what I do is I use the Clock Yourself app and have them, visualize a clock on the wall, and they keep their nose in the center so the nose stays still and the eyes move around the clock, and the app tells them what number to go to. So it's random and it's not anticipated, so it's reactionary, which is very different than anticipated movement. And then when they get really good, I have them keep their eyes on the middle, and they move their head around, so the nose moves to all the places and their eyes stay still. So we get, head on eyes and eyes on head. But anyway, those settled things down and would take the fullness out of her head, but it was only as soon, it kept coming back all the time. So, it helped. It was a nice reset, but it, again, that's what Erica talks about a lot is, the reset exercise is great, but you got to figure out, what the driver is, because if you don't, you're not going to get anywhere.
Right. And train the new strategy or whatever.
Yeah, exactly. Yeah. So
yeah.
What I needed to do was to have her learn to feel safe in a lengthened position. So I went to the bed and I took a towel roll and I rolled it up nice and firm, a long hand towel. So it wasn't thick, but it was nice and firm. And I allowed her to have her pillow, because this is not going to work if we bring symptoms on. So let's get in an asymptomatic position, shoved a pillow under her knees to relieve the neural tension in her system, and I took that towel roll and I put it right at like T2, T3, so it's right at that cervicothoracic junction. And what I was trying to do was give a lift on the thorax so that naturally gravity would bring C7 down towards the bed, which would essentially lengthen her cervical spine. So basically what I did was I put the fulcrum at the area where she wasn't moving very well, so that her head could come out of that turtle position. Thank you for that lovely graphic. Yeah.
Oh, turtle.
I know.
So she was on 2 pillows?
1 pillow. She did okay with one pillow. She didn't like it, but with a pillow underneath, she tolerated it pretty well.
Okay, so 1 pillow under the knees, 1 pillow under the head, the towel on the fulcrum under T1.
Yeah, I actually kind of had the pillow down under her shoulders a little bit too. So and had the fulcrum there. And so that just basically, and then what did we do? We did some breathing work, and I did some, breath and voice work with her. So we brought the voice down to a lower tone, like lower, breathes calming, lower tone, low registered singing, is all kind of really good, vagal toning type of stuff. But we just worked on kind of like, where do you feel this when you breathe? I started with breath as a strategy for her to start training, because the breathing, that hyper respiratory effect, got my attention when she talked about that. And I thought, here's the way in for the strategy. And perhaps if we can get her to lengthen while she's doing something that feels good to her system, and not that scary kind of breathing that she was doing, that could, be a way to kind of, start the lengthening process, but also have the movement coming through from the breath system. So no better way than to get the thorax moving in certain ways than to apply breath to it. So we just started doing, and I said, can you just kind of feel like, where does it feel good to breathe? And so we did that. And I said, where does it feel icky to breathe? And can you just kind of like come around that a little bit, kind of doing a little graded motor imagery, visualization kind of stuff, which all works with the persistent pain as well. And just kind of like approach the area, and can you just feel it change? And if that would feel good there, what would it feel like? And so we just played with that, and that became like, kind of, that was just a step more into our autonomic system quieting that we were doing in the early days. And then as we kind of progressed, we started doing arm movements with it. So, breathe in, bring your arms out like, to 90 degrees, laying on the bed like a snow angel, on the bed. How far can you bring your arms up? Oop, I feel it. Don't go that far, that kind of thing. So just kind of like working with the movement system, into it and out of it, and the whole time with that little thing there. So 10 minutes, that's enough. You don't want to put a towel roll under somebody for longer than 10 minutes because they won't like you very much. It makes her, stretches the joint a little bit and gets uncomfortable. So I didn't want her to go into that. So that was something that she could do. She set herself up. She could work with her computer. she went immediately when we talked about the eye thing, and she went immediately over to get some some glasses. She sat down and told them how, they're pretty good at that now. They ask you about what you're working on. You're on your phone or you're on your computer, how far away are you, and they can help refract the your glasses to the computer screen, and you just keep them right there at your computer. So for some people it works really, really, really well. And my suspicion is that she's approaching the age where reading becomes more difficult, so we start having to like pull away. And sometimes for not for her but for others who are wearing progressive lenses, oftentimes you'll see them drop their head into their neck into hyperextension so they can look through the reading portion of their progressives. And so that's when I like to, step in and say, why don't you get a prescription just for your computer so you can take your progressives off and put just put your computer glasses on, and you can read very well and so they don't go into that shortened position trying to like look at the bottom. It's like the people who wear the half readers are always kind of like have their head backwards, So what she did was she just set herself up. She would work for a while. It was much better with the glasses. And then she would go and lay down and do that little exercise, the breathing and kind of with the arms, and she got really clever, started playing around with her arms in a lot of different directions, and got to where she could actually lay on the floor without a pillow.
Fantastic.
And she just, she just kind of, she just really got after it, and that she really liked it. And she started to see differences, and she started to notice, this was the big thing that I found. She came in, I think it was about her 5th or 6th visit. She came in and she said, when I got on the rower yesterday, I actually started to feel that kind of thing going on, that I feel, that kind of panic. And she said, I just decided to sit a little different, drop my arms, and I noticed that I could breathe easier. And she didn't have to she goes, and it just felt more comfortable, just felt more comfortable. And here's the thing is like, okay, how did you feel 4 to 6 hours later? Well, I still had some issues, but I don't think it was quite as bad. And I said, so now are you ready to change a little bit of your exercise strategy along with this beautiful breathing strategy that you've adopted and this, kind of lengthening thing, and start thinking about, maybe what would happen if you did half and see how you feel in 4 to 6 hours, kind of like backing off of that neuroimmune response. Or I said, or slow it down to where you're still getting some cardio work, but you're not getting like way, way, way up there. Like, kind of bring it down a notch and see how you feel. So she chose to bring it down a notch. I let her choose it. Who knows? We're just at this point, we're just strategizing. And that seemed to also help the neuroimmune response down the road. So she has dialed her exercises down a notch, and that's okay. You got to meet them where they are. I can't take that away from her. That's what she wants to do it. I've just got to help her figure out a way to do it where it's not, making her system go insane. And
well, if you think about it, the rower is like a neural glide. You got your arms fixed, you're flexing and extending your legs, your feet are in dorsiflexion.
Yeah.
Right. And you're just boom, boom, boom. So that was a glider and a slider, whatever you want to call them.
Yeah, perfect.
Right then and there.
But she was, able to start coping and, and dropping, so we kind of talked about when she goes out into full leg extension that, can you start thinking about letting your head drop down a little bit, your chin, so that she could get that glider slider thing going on.
Right.
And she was able to do it because we had done the work, for her to, she had played around with the, the towel roll and the stuff to allow her to get, some lengthening in that system. So then immediately we've gone back to the squatting with the door, back to the, the wall, downward dog on the wall, closer to, working her system, and now adding the head, getting her arms on the wall, her legs are straight, and now she's just working from the head. And then she can work, from the trunk by bringing her hips forward and then back, and then she could drop her, those glider sliders that way. So we could get the neural tension piece involved as well. And we continued with the eye exercises because I really felt like she needed to be much more nimble. She was such an eye, visual strategist that I wanted her to have that, ocular cervical kind of thing. And whenever she would work her eyes, she would say that she would feel her neck and head would feel better. It just would feel better. Less fullness, less stuff. But the best part was that she was able to sleep with only one pillow and not two. So she was making some really good changes, and she's done really quite well. She still has to manage her symptoms. There's no question. When she's overstressed, when she's got a lot on her plate, when there's a lot, she has her things come back. For the pelvic health people out there, I was able to help her identify some foods that were inflammatory. I got her to stop snacking so much, so that her GI system would have a rest. And when we dropped her exercises down a notch, the bloating started to change. So that was, the bloating was coming on because she was just like high intensity throwing herself into acidosis, and the GI system is like, bleh! It's not going to work at that point. And we get all that bloating. So that helped. And then, of course, a little bit of fluid management, get off the bladder irritants. And, that also kind of helped. Again, these are all tertiary things. You could do that, and it's going to make the urgency frequency system a little bit better, but we had to also change that driver, and for that whole system to come down, because the GI bloating and the over recruiting pelvic floor and the urgency frequency that kind of comes along with that were all symptomatic of being in flight and fight all the time.
Right, response threat. Yep.
Right,
absolutely.
and the breathing techniques weren't going to cut it unless we could get the lengthening of that system. And I really feel that there was like some dural stuff in there, and it just, you got to go. I'd love to hear your thoughts on dural pieces, because it's always been my experience that if you go at it with too much, it just flares like crazy. It's not. You got to find a non-aggressive approach. But I'd love to hear yours, because I know you've read into this several times.
Yeah, I've noticed that when I have patients who have dural issues, I'll go through a process, and I'll make a modification to one region of the body, and then their foot will invert or their head will go in. And that's a system that doesn't like to be lengthened, and that person has a long history, similar to your patient. And it's funny, I had a couple of patients probably a few months ago. It was like I would like make a modification to their hip, their foot would invert. I would make a modification to their head, their tips, their thorax would twist. So when you see those people, you're giving them the ability, or you're taking away their ability to shorten, right? So what happens is you're modifying one region, and then they're like, well, I don't really like my body to be lengthened. So anyway, from a treatment perspective, I loved all that stuff. I would do very similar, but I also I've done, especially with patients who like are really like not symptomatic, but like you like breathe on them and they're like all of a sudden twisted. Like I'll have them, literally lie on a just supine with their feet over a box 90. I'll just have them like dorsiflex and plantar flex, or I'll just have them knee extend, dorsiflex, the whole straight leg raise, neural glide thing. Then I'll get them then I'll keep them on the box, and then I'll have them do, what you were doing, arms, move the arms, do figure eights, things like that. And also just lower trunk rotation off the box. It just depends on the person, but your person was an upper, like the cranial dura with her history. My experience is there are absolutely restrictions up there, and you can compensate really well until you can't, right? So getting her involved with the arms, you can affect it distally. If like the person was highly irritable, you could try like distally, but doing like a proximal with the head and doing with the arms is a way to nudge the system, right? And the image of the turtle, I learned that some years ago, and the person's just shrinking. They don't want to be lengthened. And if someone's really, and so my advice is with people who are listening, if you have patients that whatever you do and like nothing works and you've done it all, look into this neural tension piece, and there's many ways you can have them stand on a foam roller, half foam roller to take the dorsiflexion out. You can even just get them like, on the Pilates Cadillac and do the roll down. And I guarantee you, she probably couldn't have dropped her head at all. She couldn't have done it.
So
exactly. Things like that, but you have to recognize the signs first. In my experience, it's that, and I usually see this in the first 1 or 2 visits, you'll see you'll see that inverted foot. You'll see, I had a patient recently, I got him on the wall, and I said, just straighten your leg out. He straightened his left. He's like, I can't straighten my right leg out. Like, he could not straighten his right leg out, Susan. Feet were on the floor, his hands were on the wall. He was committed to the posture. He couldn't straighten it out.
Yeah.
He could not straighten the leg out.
That was her. She couldn't drop the head down. Yeah.
Exactly. I said, take your arm off the wall. He's like, oh, I can do that now. So that is either a dural driver or a dural vector or something dural that you need to get treated, right?
Yeah.
And so that I see that quite a bit, but it's you have to suss it out, and figure out what part of the dural system is it coming from.
And it's interesting because, remember in the very, very beginning, if you go back and listen to podcast 107, her posture and standing was to the left. Your pelvis was to the left. She was not on the right leg. And that was another sign that she could stay probably shortened. And when she came over, her foot, it was hard for her to put her foot flat on the ground. But when she squatted, because she was shortening, she could keep her feet on the ground.
Yeah.
So, but her head had, and she would only go halfway. She would say it was because of her pelvis, but I can tell you it was because she couldn't keep her head shortened to go down further than halfway.
Yeah. So and with the boxing, there's so many.
Kind of the top of the picture to kind of think about. We're always so focused on what are their hips doing? What are their feet doing? Look at what their head's doing.
Right. Right. If you think about like in the was this Sesame Street with Bert and Ernie? Like Ernie had the really long head and Bert had this, or the vice versa. It's like you see some of the very sort of shortened heads, right? They just don't want to. Like, I don't like, that's the feeling that you get, like the turtle's head going into the shell, right? And that was her issue. That was her area of meaning. I had a patient who literally her foot would invert on the table. That was her. She was a runner, right?
Yeah.
So I don't know. I think those are certain signs that you need to look at the dural system as well.
Thank you. Thanks for those insights. And I love the idea of like, if she was, if she couldn't do her arms, to go ahead and put the feet up on a ball or a box and, and have them start, in a safer position distally, kind of getting the movement going and, really beginning to tug at the system from below rather than from above, to help, and eventually you have to move it both directions, but you got to find the right way in first and get it going.
Yes.
And it seemed like the breathing system was the way in for her, because that was one that was like near and dear to her heart. And she really discussed it quite a bit about her exercises once she started seeing how all these pieces were kind of coming together. So it may have been a refractory problem, visual strategy, vestibular getting stuck because of the visual strategy, but also because it wasn't moving. The vestibular system did not want to lengthen her, let her go into lengthening, because it got used to being in that shortened position, her head and neck being in a different position, and just really kind of attaching that to all of the things, rather than just change your diet and eat this, your bloating will go away. It's like, no, it's a whole systems approach in to getting that to start to change. It's not going to be something, this wasn't a visceral driver, it was a visceral reactor. To a dural driver, the pelvic floor is a visceral reactor, the bladder is a visceral reactor, and oftentimes the bladder can be the driver. We've talked about visceral drivers before, but this one was definitely, a visceral reactor, and that's what happens when we stay in survival mode all the time. It's not, that's why it's not, chronic stress isn't good. Yeah.
Right. And she loved to move. So, nerves are bloodsuckers. They like movement.
Yep.
So awesome. Great case, Susan.
Thanks, everybody. We will see you next time, and hang in there and join us on our subscription. We'll have that open. This is November when this is going to be coming out, so it will be open, this month, and we're going to have live question and answers once a month. We're going to have a way for you to put your questions in and get in touch with us, throughout the month. Plus, we're going to be starting some really cool discussions with people around the country, Canada, hopefully some people from Europe too, and Australia, on what they're doing and how they're treating some of their complex clients, whether it be coming in with, whatever the drivers may be, we're going to get to be able to bend their ear a little bit and take a poke into their world and see what's going on and how they're doing it too. So that's only going to be available on the subscription. So we definitely want you to be there with us and be part of our community there. So thank you. And
thank you, everybody.
See you next time.
See you next time. Bye.